on 3D. Sometimes when we put the colors on the umbilical cord, we can see the message. This is angiosperm of umbilical cord. What you can do? Is there any pathology? Anybody can comment it? Cord is there. Yes, cord is there. No pathology. A bunch of cords would make false impression of a cord knot, like in this case with 3D reconstruction. A case of two umbilical knot, you can see this knot. This position of knot can cause problem. Color Doppler is helpful in detection of umbilical cord, false and true knots of the cord, hemangioma, angiosperm of the cord, hypoplasia, hypoplastic umbilical artery, fusion of the two arteries into one, a single umbilical artery, they can be picked upon by the help of color Doppler. Now, this is two vessel cord. In normal umbilical cord, there should be two arteries only, but in this case, only one vein and one artery, and we can prove it on color Doppler. Now, as I have already said, the umbilical artery is there to originate from one side of the universe. So, on that side, it is absent, so it will be two vessel cord, a single umbilical artery. This is normal division of umbilical artery from each side of the universe. Abnormal cord coiling. There is non-coiled cord and fully coiled cord. Its frequency is around 4 to 5%, and it has been suggested that these cords are certainly less able to resist external compressive forces. These are the associations with these types of problems. They can cause IUGR. There are too many loose hypercoiled cord, and it also can be associated with IUGR and many things. This is the example of hypercoiled cord. MCA Doppler, middle circular artery Doppler. This is circle of the fetal skull. We are seeing the fetal skull in which there is circle of Willis, and the cerebral circulation is normally a high resistance type of circulation. The middle circular artery is most accessible cerebral vessel to ultrasonic imaging in the fetus, and it carries more than 80% of cerebral blood flow. In the presence of fetal hypoxemia, central redistribution of the blood flow occurs, resulting in increased blood flow to the brain, heart, and adrenals, and a reduction in the flow to the peripheral and placental circulation. This blood flow redistribution is known as the brain sparing flux and plays a major role in the fetal adaptation to oxygen distribution. ये सारा प्रोसेस कहाँ से शुरू होता है? सबसे पहले fetus को हाइपोक्सीमिया होगा, उसकी वजह से जो ब्रेन की तरफ उसका फ्लो होगा वो बढ़ जाएगा, डॉक्टर उसको पिक करेगा और ब्रेन स्पेरिंग इफेक्ट हम पे कर लेंगे, that shows redistribution of flow in the fetus. मिडल सर्कुलर आर्टरी और ये उसका फ्लो पैटर्न दिस इज नॉर्मल. इसमें डायस्टोलिक कंपोनेंट बहुत थोड़ा होता है नॉर्मली. पीक सिस्टोलिक वेलोसिटी समय मिलेगी 50 मिलेगी और जो एंड डायस्टोलिक फ्लो है ये कम होगा नॉर्मली और एबनॉर्मली आएगी. तो व्हाट विल हैपन, एंड डायस्टोलिक फ्लो बढ़ जाएगा और ये रेशियो जो है ये कम होने लगेगी. और मैं इसको कहता हूँ कि जब फीटस नॉर्मल, जब फीटस में फ्लो एबनॉर्मल होता है तो जो अम्बिलिकल आर्टरी डॉक्टर है वो एमसीए वाला पैटर्न ले लेती है और जो एमसीए वाला डॉक्टर है पैटर्न है वो अम्बिलिकल आर्टरी वाला डॉक्टर पैटर्न ले लेती है. यूट्राइन आर्टरी डॉक्टर बहुत डिस्कस कर लें. इसकी इंपॉर्टेंस पहले ही शुरू हो जाती है नियर 20 वीक. अब फिर 20 वीक हमें पोस्ट सिस्टोलिक नॉच मिल सकती है. दिस इज पोस्ट सिस्टोलिक नॉच. Diastole, post-systolic knot. This is a normal feature up to 20 weeks. But up to 24 weeks, ये abolish हो जानी चाहिए. So there is normal flow velocity they form from the uterine artery at 24 weeks of gestation. There is no notch. This is normal in 24 weeks. और अगर ये notch persist करेगी, तो that can precipitate into eclampsia, preeclampsia. So you can pick it up at 20 weeks, 24 weeks. See the venous Doppler can be done. Venous flow, IVC. This is color Doppler examination of infravena cava, normal pattern, and this is abnormal pattern. This is ductus venosus. Ductus venosus bridges between a bladder vein and the ilioid cava, and we pick up the flow from here. And this is normal type of blood flow. This is the normal venous section flow pattern. Usually this A wave doesn't touch this baseline, but in case of problem, there will be a reversal of that A wave. At least 1/3 of the cases show early signs of circulatory deregulation 1 week before biophysical profile deterioration. हमारे कई लोग बायोफिजिकल पे बहुत जोर देते हैं, बायोफिजिकल वो पिक ही नहीं करता, जो डॉक्टर है वो पहले पिक कर देता है। कार्डियक डॉक्टर सर को मैंने देखा है, वो इसको डिस्कस करेंगे। गेन ऑफ गैलन डॉक्टर कॉपी ने बता दिया आपको कि वो वी कैन पिक इट विद द हेल्प ऑफ दिस कलर ऑफ pulmonary circulation. You can see fecal circulation. Then this is abdominal aorta of the fetus, origin of renal artery. जब शिड्यूल का एजेंसिस होगा तो renal artery भी हमें नजर नहीं आएंगे. And this is bifurcation of the fecal aorta. This is normal Doppler of the fetus, origin of normal renal artery. Unilateral renal agenesis, एक साइड की है, एक साइड की गायब है, और bilateral renal agenesis, which is incompatible with life. So, with the help of color Doppler, we can command and diagnose these. ये कुछ थोड़ी सी जो pelvic अल्ट्रासाउंड में pelvic जहां पर भी हमें मैच मिलेगा, we try to use Doppler. जहां पर भी हम complexes देखेंगे, we try to put our colors on simple, yes, but it can be. Anybody? Pelvic listed, but it can be. Color Doppler यार ऐसे नहीं नजर आ रही है, ruptured follicles are simple, but we can confirm it with the help of color Doppler. Solid mass, complex cystic masses, अगर हमारे पास Doppler है, we should try to put our Doppler. इस तरह ruptured hemorrhagic ovarian cyst. These are the examples of these are benign conditions of pelvic masses and benign and some. These are very large cysts, and if we have color Doppler, we try to find is there any solid component in that, and that solid component pick up the color. An interesting case after C-section, there is thrombosis of the pelvic vein. We can also put our color in that problem to assess. This is a power Doppler sonogram. This image shows increased flow to the wall of the tubo-ovarian abscess. There is tubo-ovarian abscess here, and there is all flow. The inner hypoequilibrium are due to presence of fluent material. This is abscess. Ovary oophorytis. In case of oophorytis, we can also pick that problem with the help of color Doppler. So, we are seeing these colors due to increased blood flow due to oophorytis, inflammation of the ovary. Again, this is pyrosalpine. We are putting our colors, and we are seeing other inflammatory and other conditions of this. This is a very mass, complex mass. We are putting the colors, fibroid. Again, a pelvic mass. Cervical carcinoma will take up lots of colors. Sometimes the DVT is after prolonged illness, after pregnancy, or we have to see whether the DVT is there or not, DVT is thrombosis. So there is no blood flow here in the vein. This is our DVT. Thank you. Thank you.
After this nice presentation from Dr. Tawseef Kamar, I would like to invite Dr. Khalidul Jamali for his presentation of first semester personal publications. Dr. Khalid, please. Meanwhile, I welcome Dr. Musarraf Hasan from Karachi. We are thankful to him. He has always helped us in Punjab for upgradation of our knowledge.
examination.
Introduce us to the first trimester ultrasound. I will be showing you the complications and various abnormalities which can be seen in first trimester ultrasound. It can be done transabdominally or transvaginally. These are the things which we will be looking for: gestational sac, embryo, fetus yolk sac, twins, multiple pregnancies, lighter amount, placenta and heart, subchorionic bleeds, abnormal presentations, for example, ectopic pregnancy, heterotopic, abdominal pregnancy, mole, and different types of abortions, and coexisting pathology. Real-time scanning, M-mode, Doppler, and cardiac activity and heart rate are important to judge on ultrasound. And on TDS scan, the cardiac motion is detectable at round length of the 5 mm. If there is no cardiac activity, then wait for 1 or 2 weeks and re-scan the patient for follow-up if the embryo is smaller. Here is the picture. Sometimes the sac is distorted because of Braxton Hicks contraction. And underneath the developing placenta, you can see the increased vascularity. Another Braxton Hicks contraction, and the idea was distorting the sac. Otherwise, pregnancy is normal. A normal cystic structure in the fetal skull head is the fourth ventricle, propancapilla. Crown of length is the most accurate in calculating the gestational age. Physiological bowel hernia can persist up to 11 weeks. This is the herniation which has persisted beyond 11 weeks. Early detection of the anencefali is possible at around 10, 11 or 12 weeks, where you will see that calvarium is not developing. These are some of the slides where these values are to be kept in mind. Gestational sac should be visible if beta HCG level is 1000 to 2000. Early gestational sac. Yolk sac should be visible in gestational sac of 8 mm size on TDS. If you don't see these findings in this order, then the early pregnancy failure is diagnosed. This is a separated uterus. On one side you can see a gestational sac and yolk sac. On the other side, the endometrium is also showing the decidual reaction. And sometimes the bleeding from the other side continues during pregnancy. Yolk sac should be visible in gestational sac of 20 mm on transabdominal scan. This is the yolk sac here. Embryo should be visible in a gestational sac of 16 mm on TDS. And embryo should be visible in gestational sac of 25 mm on transabdominal scan. If these things are